All right, everyone. Thank you for staying for our last talk today. And we'll have Dr. Sue introduce Dr. Ravi Vij.
Hello. All right. Well, thanks for staying, still being here. So yeah, I've got the pleasure of introducing Dr. Vij. Dr. Ravi Vij is an associate professor at Washington University School of Medicine in the Division of Medical Oncology, section of bone marrow transplantation and leukemia. Primary academic interests are treatment of hematologic malignancies and hematopoietic stem cell transplantation, research interest in multiple myeloma and AML and myelodysplastic syndromes. He serves on numerous committees, including the International Myeloma Working Group, the Core Transplant Myeloma and Leukemia Committees of CALGB, and the Steering Committee of the Multiple Myeloma Research Consortium, as well as the Myeloma Committee of the BMT Clinical Trials Network. His honors include the Multiple Myeloma Research Foundation Innovator Award and the Multiple Myeloma Research Consortium Center of Excellence Award. So welcome. We are thrilled to have you here. Thank you.
Thank you. Thank you very much. I'm going to talk in this hematology section on multiple myeloma. That's an area where I've increasingly narrowed my clinical and research focus to, and there's plenty to talk about in myeloma itself. So hopefully for the broader hematology update, there'll be other venues to update. But as far as the objectives of this talk goes, it is to identify new data in the treatment of newly diagnosed myeloma, to review the advances in the treatment of early lines of relapsed and refractory myeloma, and discuss advances in the treatment of triple-class refractory multiple myeloma. So we'll break it into 3 sections. So multiple myeloma, I don't need to tell this audience, is a disease that is growing both in incidence as the population ages and in prevalence. It is felt now that perhaps close to 36,000 new cases, and some people talk about up to 200,000 prevalence as treatments have got better. So the median age remains about late 60s, early 70s, and it is the second most common hematological neoplasm in the United States. So what are some of the recent advances in frontline therapy? We will review those, but before we do so, the role of initial therapy is to produce a deep response. And deep responses do translate into better progression-free and, in most cases, even overall survival. Finally, the FDA seems probably coming around to this as well. We're still awaiting their final decision, but a recent ODAC recommended that MRD negativity or sustained MRD negativity be a surrogate for new drug approval, because as you will see, we are getting better and better PFS. And for companies to continue to invest in this area, it is important that we be able to provide early readout from trials to provide new standards of care. So MRD is still mainly a research endpoint, but may in the future come to clinical practice as well. So, and we do tend to use our best treatments in combination upfront for another reason as well, because we know that there's also a drop-off in number of patients progressing through each line of therapy. So if you leave your best for last, saying you will not have options for later, then a lot of patients, it is felt that somewhere in the early lines of therapy in the real world, up to a third or more of patients fall off in each line of therapy. So the initial treatment approach in myeloma hasn't changed in over nearly now 3 decades. For patients who are transplant candidates, it is still recommended that stem cell transplantation be considered as part of initial therapy. And for others, obviously, induction therapy with combination drugs. What has changed is what are the induction therapy for transplant eligible and what are the frontline regimens for transplant ineligible patients. And that is what we will review, some of the recent presentations in this area in the last year or so. So one of the things that we now have is that we are moving from an era of 3-drug induction for transplant-eligible patients to 4-drug inductions. And this is now something that is thought to be the standard of care. And the 2 trials I'll discuss here in the transplant-eligible population tell us why. So the Perseus study is one that was presented at the ASH meeting in December 2023. Prior to this, we had the Griffin trial that was a randomized phase 2 study that had already established, for most part, the use of 4-drug regimens in the frontline transplant-eligible population and had received NCC and compendia listing as of over 2.5 years ago. But Perseus is the first phase 3 study. Patients were randomized to VRD versus Dara-VRD. There was slight difference in the VRD schedule in the Griffin and the Perseus studies. In Griffin, it was a 3-drug regimen. It was a 3-week regimen with Revlimid given 2 weeks out of every 3. In Perseus, it's a more traditional 4-week regimen with Revlimid given 3 weeks out of every 4. Patients were afterwards taken to transplant, and there was built into the trial consolidation phase. This is not usually something that is in clinical practice thought to be a routine, but it is perhaps for select patients of utility. And post-consolidation, patients who got the 3-drug induction got Revlimid maintenance. Those that got the 4-drug induction got data with Revlimid maintenance. And there was a further randomization to see whether we could abbreviate the period of therapy. This part hasn't been reported on yet, but at the data Revlimid arm, if patients are MRD positive, they continue data rev till progression, and MRD negative, they discontinue the data and continue on Revlimid alone. And what we see here is that there was a statistically significant hazard ratio of 0.42. That's a roughly 58% reduction in progression-free survival with a median follow of about 4 years, 84% versus 67%. And what we see is that the depth of response was as expected. When you already have a progression-free survival advantage, this is nearly a foregone conclusion. That MRD negativity, traditionally defined as 10 to minus 5, one cell abnormal in 100,000, was better in the 4-drug regimen. As you can see here, this was at various points in the treatment course. And what we also know is that another presentation at the plenary session of the American Society of Hematology meeting looked at a slightly different 4-drug regimen, which is isatuximab with Kyprolis, Revlimid, and dexamethasone, and compared it to the 3-drug regimen of Kyprolis, Revlimid, and dexamethasone. Now, for some institutions, KRD is still thought to be the best induction as far as proteasome inhibitor goes for patients who have high-risk disease. So this has potential utility, especially in high-risk patients, where in this trial, patients got 4-drug regimen versus 3-drug regimen. And once again, there was a consolidation phase, and then patients continued on either KRD or ISA-KRD for a total of 12 cycles. And what we see here in this study is that we have statistically significant improvement in MRD negativity rates, both at 10 to minus 5 and 10 to minus 6, as you can see in here, favoring the 4-drug arm. Now, in this trial, data was not mature regarding PFS, but the fact is, as I said, generally the superior depth of response translates into PFS with longer-term follow-up, and it was the plenary session at ASH. And the fact is that we do see that the MRD negativity rates do improve with time, post-induction, post-transplant, post-consolidation, and in each case follow the same pattern of the 4-drug regimen outperforming the 3-drug regimen. And post-consolidation, 77% achieved MRD negativity, which is pretty spectacular. I think that we were happy if we had response rates of 70% 20 years ago. Now we're talking about 77% MRD negativity rates post-transplant. And even at 10 to minus 6, you can see, as I said, these are statistically significant. Another recent presentation from the ASCO meeting that I'll just talk about is about the transplant ineligible group. As far as transplant ineligible patients for myeloma go, they have historically, increasingly recently been treated with 3-drug regimen of daratumumab with lenalidomide and dexamethasone. There's still some use of dose-reduced VRD or VRD light. But now it seems we may be entering the era for at least some patients that are not headed to transplant to be able to get 4-drug regimens. And this is the IMROS study that was presented, wherein patients got isatuximab with Velcade and Revlimid and dexamethasone and compared to VRD given in the traditional manner. And patients got 4 6-week cycles, and thereafter the Velcade was stopped because that is often considered, especially in an elderly population, a drug that is not amenable to long-term administration. So this seemed to be a user-friendly regimen. And thereafter, patients were dose de-escalated to isatuximab Rev-Dex versus Rev-Dex treatment until progression or unacceptable toxicity. And what we see here is, once again, a very significant improvement in PFS, hazard ratio of 0.59, representing a 40% risk reduction in the risk of death compared to VRD. Not included in this slide set was another presentation in the oral session that compared VRD light which compared isatuximab with RD to VRD light, and showed that the addition of Velcade did improve outcomes. In that study, isatuximab was obviously in both arms. And what we see here is the tolerability. As expected, there is some neuropathy associated with patients getting Velcade, but overall the rates of grade 3-4 toxicity are not much different in the 2 arms. A slight increase certainly in the risk for neutropenia, a grade 3, and perhaps a little higher risk for pneumonias, but by and large it was well tolerated. So this will go before the FDA for approval, and will probably before that enter compendia listing for patients who are not headed to transplant. So another advance in frontline treatment. So these are 3 major trials that have been presented in the last 6 months that are changing the landscape of frontline therapy. We will now move on to early relapse, which is generally defined as patients needing their 2nd to 4th line treatment. And here too, we've seen major advances in the treatment options. What we know is that over the last couple of decades, we moved from 2-drug regimens for salvage to 3-drug regimens traditionally. And these were with a series of trials, first of all, that compared 3-drug regimens to a control arm of lenalidomide and dexamethasone. As you can see, I'm not going to go into any of these trials in detail, but carfilzomib, lenalidomide, dexamethasone, ixazomib, lenalidomide, dexamethasone, elotuzumab, lenalidomide, dexamethasone, and daratumumab, lenalidomide, dexamethasone, all received FDA approval in randomized phase 3 studies for patients that were not progressing after 1 or more line of therapy. Another set of trials looked at improving the outcomes over a 2-drug combination of pomalidomide and dexamethasone. And shown here are the trials done in this regard. Again, all phase 3 studies: isatuximab, pomalidomide dex, elopom dex, and darapom dex. More recently, at the ASCO meeting, we saw the results of the DREAM-8 study that I will briefly go over, since that is new data. And here what we see is the trial. As you know, belantamab or Blenrep was withdrawn from the US market nearly a couple of years ago, I think now, because it was first given accelerated approval, and thereafter a trial comparing belantamab to pomalidomide and dexamethasone failed to meet its primary endpoint. But this is one of two trials now that are likely to bring the drug back to the market. And we will talk about both the trials presented at the ASCO meeting. First, as I said, the belantamab pomalidomide dex versus pomalidomide dex study. And here what we see is that there was a statistically significant improvement in progression-free survival, a hazard ratio of 0.52, representing a 42% risk reduction when belantamab was combined with pomalidomide and dexamethasone versus giving pomalidomide with Velcade and dexamethasone. So this was actually a 3-drug regimen to 3-drug regimen trial, a higher bar to cross, obviously, in comparison to all the other 3 versus 2 drug regimens that we had talked about. So at 12 months, a 71% PFS versus 51%. What obviously has been a concern with the use of belantamab has been its ocular toxicity, and we did see that the grade 3 or higher ocular toxicity was seen, any event was seen in 43% of cases. We have, I think, got a little better at managing this toxicity with the use of more spaced out regimens. Often the drug is now being given every 6 weeks instead of every 3 weeks. So there is still much to be done to reduce ocular toxicity with this drug, but is likely to get FDA approval and re-enter the market based on this trial. Another group of trials that we've had over the years have improved upon, first of all, 2-drug combinations of bortezomib and dexamethasone. So we went through improvements over RevDex, PomDex, and now we're talking about proteasome inhibitor dex, or either bortezomib dex or carfilzomib dex. And again, without going through each one of these studies, it showed that the 3-drug regimens shown here, all of which received FDA approval, were better than the comparator 2-drug regimens. And what I will talk about, though, is the data that, again, was presented at the ASCO meeting on belantamab with bortezomib and dex compared to bortezomib and dex. And this is the clinical trial here. And this is a trial that compared, as I said, belantamab, bortezomib dex to daratumumab with bortezomib and dex. And in this study, once again, there was a statistically significant improvement in progression-free survival at 18 months, 69% versus 43%, with an even more impressive hazard ratio of 0.41, suggesting a nearly 60% improvement in progression-free survival. So once again, we do see ocular toxicity emerge as one of the side effects that we will need to be able to tackle. Those regimens are, as I said, not going to be possible to be used immediately, but in the months to come, hopefully they will be FDA approved. But what we have already seen is a change in the landscape in the 2 to 4 line therapy in the last several months, since now April, the approval of CAR T cells, both cilta-cel and ide-cel in earlier lines of treatment. We'll first review the data on ide-cel. Ide-cel was compared in the KarMMa phase 3 study to traditional standard regimens for patients who had progressed after 2 prior lines of therapy. These patients, you will see on the table in the right-hand side, they were in 95% of cases dara refractory, which is to be kept in perspective as you compare the results across the KarMMa 3 study and the CARTITUDE-4, which was the study looking at Carvykti, the other CAR T. So here we see statistically significant improvement in overall response rates, 71% versus 42%. And as on the table on the right-hand side, the median duration of response went from 9.7 months to 16.6 months. And if you look at PFS2, it was 16.7 months versus 23.5 months. And obviously, those patients who achieve a CR do much better than the median shown for the whole population. And this gives you, in Kaplan-Meier fashion, the PFS 13.8 months versus 4.4 months. So these were mainly patients who were third, fourth line or beyond. So this led to the FDA approval of ide-cel in this population. And if you look at survival, that was not met, but the fact is that very difficult these days to show survival advantage in myeloma studies, often because of the plethora of options available to patients to take after they come off trial. But if you also look at the fact that the trial design allowed for crossover, allowing patients who had the 3-drug traditional regimens to get ide-cel at time of progression on the study, that further confounds the ability to show a survival advantage. But if adjusted for crossover, then it appears that there was a statistically significant survival advantage of 41.4 months versus 23.4 months. So these were patients that were mainly triple class refractory. And to put in perspective, if you were talking 5 years ago, or even as little as perhaps 3 or 4 years ago, when you became triple class refractory, the median survival was about 9 months. And now you're talking about 41.4 months. This is a huge improvement in outcomes for patients. The CARTITUDE-4 study will be next. This was a study looking at the other CAR-T, cilta-cel, a slightly different population. Here, patients who had actually failed just a single line of therapy were allowed, and these patients had to be lenalidomide refractory. And as you can see, only a minority of patients, 23% instead of 95% in the KARMA study, had been exposed to daratumumab and were refractory to it. And here, once again, what we see is that the response rates and the depth of response especially favored cilta-cel, 84% versus 67% for overall response. And if you look at really the CR rate, that actually magnifies for you what really the difference is, nearly 73% versus 23% for CR rates. And MRD negativity, as you can see on the right-hand side, very different in the intent to treat population, going from 15% to 60%. And what we see here is the progression-free survival. It was not reached with a hazard ratio, which is very impressive, 0.26, representing nearly a 75% improvement in outcomes of these patients as far as PFS goes when you use a CAR-T compared to traditional 3-drug regimens. And as expected, the less heavily pretreated you were, the more longer the PFS. So next we will shift to trials looking at patients in later lines of therapy that are, the 5th line plus space. Selinexor, not a new drug anymore, but worth a mention because it has had, I think, increasing utilization, especially in the era when CAR-Ts were limited to 5th line plus. It was often a drug that hadn't been seen by patients in earlier lines, and that traditional 4th line space has been often nowadays been taken by selinexor-based regimens, and it also is something that we've used, at least when limited to later lines of therapy, CAR-T, as a bridge to CAR-T. And though it was initially approved as a 2-drug regimen given twice weekly and got limited use because of its toxicity, combinations looking at it given once weekly in much lower doses seem to be much better tolerated. And the drug got approved after its initial accelerated approval based on a phase 3 trial, selinexor bortezomib dex versus bortezomib dex, approved for patients who had one or more prior lines of therapy. Now, in the real world, we are using it much more commonly in with other drugs in combination. And the one that I tend to use often is selinexor with Pomdex, XPD, or selinexor with Kyprolis dex, which is XKD. And what we know is that these 2 regimens seem to do very well in patients who had prior triple drug exposure and are triple drug refractory. As you can see here, the treatment response in patients who have had these triple class of drugs is a respectable 8 months for XPD and 13.1 months for XKD. The toxicity profile of the drug has historically been one of GI toxicity, and at the 80 milligram dose twice weekly, that was very much to be expected. We, however, use doses of 40 milligrams once weekly now instead of 80 milligrams twice weekly when combined with Pomalyst, and 60 milligrams once weekly with Kyprolis. That has made this much more bearable. And previously, giving multiple antiemetic agents and often need for IV fluids, but that seems to be less needed in these lower once weekly combinations. A passing mention about the initial approval of Cilta-cel and ide-cel that was till a few months ago limited to patients who had had 5 or more prior lines of therapy. And these were accelerated approvals, ide-cel with a median PFS of 8.8 months, and Cilta-cel with a 27-month PFS of 54.9 months. Again, cross-trial comparisons are difficult. These were slightly different populations, but suffice to say that we have now had both these drugs available for use for the last few years, and they are now moving into earlier lines of treatment. But what are we doing in later lines today is still a lot of bispecifics. So we'll talk briefly about the 3 bispecifics that have received FDA approval. First is teclistamab, which is a bispecific to BCMA, the same target to which the 2 CAR T cells, ide-cel and Cilta-cel, are approved. And bispecifics are certainly advantageous in that they are off-the-shelf products. They do not require the wait for insurance approval and the vein-to-vein time that can stretch to sometimes several weeks in the case of CAR T cells. They are more immediately available for patient use. And in the case of teclistamab, the trial that led to its approval was the MajesTEC-1 study. All of these bispecifics, as you will see, go through a ramp-up phase that requires starting at a low dose, going to a middle dose or 2, and then going to the full therapeutic dose. And that is done to reduce the CRS and the neurological toxicity associated with these drugs. Most institutions have been doing this as an inpatient, though increasingly centers that have started doing CAR T cells outpatient have ventured to start giving these as an outpatient. I wouldn't recommend that it be done yet in a community setting unless you've thought through how you will be able to manage these patients in an outpatient setting, because CRS and neurological toxicity does mean that you need to have SOPs in place to manage these complications, often with drugs like trastuzumab as an outpatient. But what we see here is teclistamab has a very impressive response rate of 63% in patients who had had 4 or more prior lines of therapy. And the median duration of response, as you can see, very respectable over here. These drugs overall 21.6 months and 26.7 months for those that went into complete remission. So once again, putting in perspective that in the 5th line plus, historically, we've had a median PFS of about 3 months. And here you're seeing 26.1 months for the population as a whole. And if you go into CR, which as you can see here, about nearly half the patients do, then it hasn't yet been reached even at over 2 years. And the safety of these drugs, again, CRS and neurological toxicity we talked about, these are certainly much less likely to be grade 3, 4 than our CAR T cells, but still require the expertise in management. One other thing about these is the need for repetitive administration. Teclistamab is now approved for use every 2 weeks between month 1 and 6. And then if patients have had a good response, once a week, and then can go to once every other week. off-trial institutions are looking at their own schedules and actually giving the drug in what they call the DARA schedule, which is giving it once a week for 2 months, once every other week for 4 months, and then once a month thereafter. We don't have clinical trial data to support that, but what is driving that is two things. One is that responses to these agents occur very quickly. So if you're going to respond, you're going to be possibly in an MRD negative state within 2 months. And in the case of T cell exhaustion too, it appears that giving it less frequently may abrogate that problem, because one of the mechanisms by which these immunotherapies seem to fail is by the T cells getting exhausted, though other mechanisms like loss of target and microenvironment changes probably also are driving some of the resistance to CAR Ts and bispecifics. T cell exhaustion is one of the major issues, and that seems, at least based on preclinical data, to be less likely to happen if the drug is given less frequently. So hence the move to try to give it less frequently already. The other thing is that these drugs are associated with an infection risk. CAR Ts actually are probably less likely to cause an infection than bispecifics because of the long-term nature of the immunosuppression that bispecifics produce. We do generally recommend giving herpes prophylaxis, but also PCP prophylaxis. And most of these patients with the BCMA-based approach do also require IVIG once their IgG level drops below 400. That is now seeming to reduce the risk of the serious opportunistic infections, because in the pivotal studies, there were deaths as these drugs were developed in the COVID era for sure, but there were also some infections that we tend to see in allogeneic transplant patients like CMV, adenovirus, PJP. Those seem to be declining with the use of these prophylactic strategies, but still vigilance is needed. What we do see very frequently is the common upper respiratory tract infections and some pneumonias for most of the infections. That's what happens. The other drug that got FDA approval more recently, again directed towards BCMA, is elranatamab, and this was also approved based on accelerated phase 2 study design. In this study, they had 2 cohorts, patients who had a prior BCMA exposure and those who had not. And what we see here is that overall, once again, for the whole population, the response rate was a respectable 61%. And PFS, once again, not reached for the whole population. And the drug does work when patients have had a prior BCMA-based treatment. That's not unique to the use of elranatamab. Even teclistamab has activity in BCMA exposed patients. So in the trials that were done, patients had received ADC, Blenrep, which was on the market, and CAR Ts. What we, however, know is the reverse may not be as good. Giving a bispecific real-world data before CAR T seems to suggest low durability of CAR T durability. That may be perhaps related to the proximity of the treatments. In the case of CAR T, you can get, as you see, through 2.5, 3 years even, progression-free. And it is possible that when you come in with a bispecific at that time, you can still get mileage out of going after the same target that you're failing. Whereas if you give a bispecific and you are progressing on the bispecific, getting a CAR T within the next few weeks may not be the best option. Whether giving some intervening therapy and coming to the CAR T farther down the road leads to better outcomes is going to obviously be something that the real world data will tell us in the years to come. But once again, the safety profile of this is fairly similar to what we see with teclistamab. Their administration schedule does differ a little bit with shorter periods of hospitalization, potentially with elranatamab. And the last among the bispecifics that I wish to mention is talquetamab, which is to not BCMA, but GPRC5D, which is antigen that is present on plasma cells, but also has some expression on epithelialized, keratinized epithelium. So hence in skin, nails, and the tongue. And that, as you will see, reflects in the toxicity profile of this drug. And this was again approved based on an accelerated trial design. The drug was given it had two different ramp-up schedules, and then you were giving the drug either once a week or once every 2 weeks, depending on what ramp-up schedule was approved and was used. And what we see here is that both the schedules every week or every 2 weeks led to fairly similar response rates in about 74% of cases, with penta-drug refractory patients having a fairly similar 70% plus chance of responding. The median time to first response, shown on the bottom right-hand corner, was 1.2 months. And the median time to best response, as you can see, is 2.2 months or 2.7 months. Once again, emphasizing that your responses occur very quickly. And that allows for, in the real world, potential for dose de-escalation much faster than permitted in the packet insert. And this is the durability of responses shown here, not reached for the 0.4 milligram and neither for the 0.8 milligram. The median progression-free survival was, however, as shown at the bottom, 7.5 months for the Q-week schedule and 11.9 months for the Q2-week schedule. And safety, certainly the drug has the same issues around CRS and neurological toxicity that we need to be aware of. But as I said, because of the expression pattern of GPRC5D, some unique toxicities emerge. Skin and nail toxicities. Patients can develop a rash, which usually is transient, but can be fairly impressive, treated with topical steroids usually. But the nails can get brittle, and unfortunately, nails can fall off. And more distressing is this side effect of dysesthesia, which is loss of taste, saliva production, and ability to swallow solid foods, leading to often substantial weight loss within a few weeks of starting the drug. And that we still have not been able to come up with a very good management strategy for, other than trying to obviously dose reduce and give longer dose delays if need be. In the real world, that is going to be the way forward for the time being. But as I said, because the drug works so fast and often you're MRD negative within 2 months, that may be still something that will benefit a lot of the patients. Now, one other thing is, in contrast to the BCMA-directed therapies, one thing that is good about GPRC5D is that the infection risk is much lower. GPRC5D is present mainly on the malignant differentiated plasma cells. So the generation of normal plasma cells from B cells is unimpeded, thereby, in contrast to the use of BCMA-directed therapies where we see a fall in IgG level. In this case, often the reverse happens, that the immunopoiesis actually resolves and the IgG level improves without the need for IVIG supplementation. And the last few slides, I'll talk about some of the drugs that are not yet here, but will be, I think, coming in the near future that also hold great promise. Cevostamab is another bispecific to a different antigen, FcRH5. And this has been presented in clinical trials and has, again, a response rate which is respectable of about 56%. Both the GPRC5D and the FcRH5 bispecifics have proven activity even in patients that have had prior BCMA-based treatment. So as you can see, we're talking about, with a CAR-T to BCMA, potentially getting you 3 years in a population that used to get 9 months, and then you get another year and a half with the GPRC5D. Now, in the future, you'll get even longer benefit, potentially by sequencing yet other targets. So cevostamab is certainly a drug to look forward to. Another group of drugs that is in development are what we call CELMoDs. We've all been used to what we call the IMiDs, immunomodulatory drugs, which have been thalidomide, lenalidomide, and pomalidomide. Their mechanism of action at the time of introduction into practice was not known. Initially, they were thought to be anti-angiogenic, but as the drug class name immunomodulatory drugs suggest, it was found that they were mainly working through either direct cell kill or through the microenvironment, enhancing the immune system. And what was subsequently found is that the way these cells are killed with these IMiDs is by a molecule called cerebolon, and two downstream transcription factors, Icaros and Aiolos, are the ones that are modulated by cell mods. And what we now have are drugs that are active even in lenalidomide and pomalidomide failures in clinical trials that actually targets the cerebolon even in patients who have acquired mutations. And so these are the next generation of IMiDs, so as to speak. There are two in development. One is iberdomide, and this has been presented both as monotherapy and in combination therapy. And as you can see here, in patients who have had a prior BCMA-based treatment, we can see that patients have a response rate of about 25% when combined with dexamethasone. And the other one is mezigdomide, which is another drug that has shown activity when combined with dexamethasone in multiply relapsed myeloma. It appears that it may be a little more active than iberdomide, but a little more toxic than iberdomide in terms of myelosuppression. So it is probably like lenalidomide and pomalidomide. It will be iberdomide and mezigdomide. To end, I'll just once again bring up the 1114 story, which I'm sure a lot of you are familiar with, that this translocation present in about 20% of patients with myeloma has been shown to be exquisitely sensitive to BCL2 inhibition. Venetoclax has gone through two studies. Unfortunately, as we will see, both studies failed and will probably not be available on an FDA-approved indication, but the field is absolutely certain that this drug works. We have all got patients who have been through even BCMA-based treatments and have, if 1114 positive, got even a year or more progression-free out of using either venetoclax with dex or venetoclax with Velcade in dex. And the first study that failed was the Bellini study, which was actually a trial that probably shouldn't have been done because they didn't restrict it to the biomarker 1114. They wanted all patients, got a little greedy there. And what happened is that it actually ended up being detrimental to survival. But in the 1114 population, as shown on the top curve, it maintained its superiority. And then more recently, at the IMS meeting last year, we had the Canova study presented. That was Vendex versus Pomdex. And this too, unfortunately, did not meet its primary endpoint. Without being an apologist, I think that there were methodical flaws in the interpretation of responses that probably led to this. And so I think that venetoclax is certainly not going to get through the FDA, but it is something that is good that we now have second generation BCL2 inhibitors, sonrotoclax and others that may actually get us there. So to conclude, the treatment of multiple myeloma has evolved quickly over the past decade. In the first line, 4 drug combinations, including CD38 monoclonal antibodies with transplant followed by maintenance, provide the best chance for deep, long remission. And now we see that even patients with who are not headed to transplant, at least a subset may benefit by a 4-drug regimen, currently including cetuximab. In the second to fourth line space, a multitude of 3-drug regimens have existed. They are being supplanted now with Blenrep potentially in the future, but CAR-Ts have moved in there. In the fifth line plus, CAR-Ts and bispecifics have changed the landscape of treatment. So in patients where I in my clinic now have so many patients out 12, 15 years, we probably just started to, see that the best is still, however, yet to come. So thank you very much, and be glad to take any questions.
Great. Do we have any questions from you?
Thank you. Are you giving bispecific antibodies completely as an outpatient? And if so, if they have
this presentation at ASCO. Please reading with Rosie. Yeah, so we haven't yet started doing it. We don't have an outpatient CAR T program. That will change come September. We are opening up a 12-bed unit, and at that time, where that is the intent. As I said, it is something that, yes, giving a pre-treatment with tocilizumab seems to reduce the need for CRS management. But once again, I think that it is something that can't be done without proper thought in a community setting. Would say that you should think through it. But yes, the use of prophylactic strategies are probably going to allow for greater adoption as an outpatient.
Do we have any other questions? Any
Okay.
questions?
Thank you. Appreciate it.
All right, everyone. Well, we've come to the end of our event. I wanted to thank all of you for your participation and hope that you've enjoyed your time with us. I wanted to thank all of our speakers for sharing their time and expertise with us, and thank all of our event exhibitors as well for supporting the programming. Enjoy the rest of your weekend. We do have a lot of leftover lunch boxes. So if you have hungry kids at home, hungry spouses at home, feel free to take as many as you want. So, yep. And thank you to our online viewers as well.